Assalamualaikum, Sir Amirul and my fellow classmates. Today we will be presenting on Myocardial Perfusion Imaging or MPI, focusing on stress and rest imaging. MPI is an important nuclear medicine procedure used to evaluate myocardial blood flow and assess coronary artery disease. Our presentation will cover the principles, clinical indications, radiopharmaceuticals, imaging procedures, image interpretations, advantages, limitations, and clinical case example. Okay, my name is Nur Iman Aziz Scenario, and my partner is Muhammad Iskandar bin Muhammad Yusuf. Okay, for the learning objective, at the end of this presentation, students should be able to explain the principle of MPI, describe its clinical indications, identify the radiopharmaceuticals used, explain stress and rest imaging procedures, interpret MPI findings, and discuss the advantages and limitations of this technique. Okay, myocardial perfusion imaging is a nuclear medicine procedure used to assess blood flow to the heart muscles. It commonly used to evaluate coronary artery disease. The procedure compares myocardial perfusion during stress and rest conditions. MPI is usually performed using SPECT imaging with a gamma camera and helps identify myocardial ischemia, myocardial infarction, and viable myocardium. Okay, for the principle of MPI, it's based on the uptake of the radiopharmaceutical by a viable myocardial cells. After intravenous injections, the tracer is distributed according to the myocardial blood flow. Healthy myocardium demonstrates normal tracer uptake, whereas areas with reduced blood supply should decrease uptake. The emitted gamma ray are detected by a gamma camera to produce image of the myocardial perfusions. Okay, MPI is commonly indicated for the evaluation of coronary artery disease. It is used in patients presenting with chest pain, suspected myocardial ischemia, previous myocardial infarctions, and for risk stratifications. Okay. MPI is also used after coronary interventions such as BCI or CAPG for assessing myocardial viability. Okay, for the radiopharmaceutical, the most commonly used radiopharmaceuticals in MPI are TC90M, Sestamibi, and TC90M Tetrofosmin. Okay, both agents accumulate in a viable myocardial tissue, and their uptake is proportional to the myocardial blood flow. TC90M has a short half-life of approximately 6 hours and emits 140 keV gamma photons, making it ideal for the gamma camera imaging. TC99M Sestamibi and TC99M Tetrofosmin has a similar clinical application but different biodistribution characteristics. For Sestamibi tends to have a higher liver uptake, while Tetrofosmin demonstrates faster liver clearance, allowing earlier image acquisitions. Okay, both also provide high quality myocardial perfusion images. Okay, SPECT versus SPECT. SPECT is a most commonly used modality for MPI because it is widely available and relatively inexpensive, while PET offer higher sensitivity, improves spatial resolutions, and a quantitative assessment of myocardial blood flow. However, the PET-CT is generally more expensive and less widely available compared to SPECT. Okay, why is TC99M is preferred? TC99M is preferred because it provides excellent image quality with a relatively low radiation dose. Its short half-life reduces patients' radiation exposure, and its 140 keV photon energy is ideal for the gamma camera detection. In addition, TC99M radiopharmaceuticals are widely available in clinical practice. Okay, now I will be explaining regarding the stress test. Stress imaging evaluates myocardial perfusion during increased cardiac workload. Stress can be induced through exercise, such as treadmill or bicycle testing, or pharmacological in patients for the unable to exercise. The radiopharmaceuticals is injected at peak stress, followed by image positions to assess myocardial blood flow under stress conditions. Okay, for pharmacological stress mechanisms, several pharmacological agents can be used for stress testing, such as adenosines and dipyridamole produce coronary vasodilations. Regadenoson is a selective A to A receptor agonist that also causes vasodilations. Dobutamines work differently, caused by increasing heart rate and myocardial contractility, thereby increase cardiac workload. Okay, now I will explain regarding the REST imaging. REST imaging evaluates myocardial perfusions under resting conditions. The radiopharmaceuticals is injected while the patient is resting, and imaging is performed after the adequate pressure distributions. To compare between the stress and rest imaging helps differentiate reversible ischemia from the epic portions. Okay, now I will pass the presentation to my partner Iskandar, who will continue with the rest of the presentation. Thank you.
Now, I would like to explain why we compare stress and rest images in myocardial perfusion imaging. The main purpose of comparing these two studies is to determine whether a perfusion defect is reversible or fixed. First, let's look at the top row. If we see reduced tracer uptake during stress, but normal uptake during rest, this is called a reversible defect. This finding indicates myocardial ischemia, meaning the blood supply is adequate at rest but becomes insufficient when the heart is under stress. Next, the second row shows reduced uptake in both stress and rest images. This is known as a fixed defect. It is usually suggests myocardial infarction or scar tissue, where part of the myocardium has been permanently damaged and is no longer viable. Finally, the third row demonstrates normal uptake in both stress and rest studies. This indicates normal myocardial perfusion, meaning there is adequate blood flow to the heart muscle under both conditions. Therefore, by comparing stress and rest images, physician can differentiate between reversible ischemia, permanent infarction, and normal perfusion. This information is important for diagnosis, risk assessment, and treatment planning for patients with coronary artery disease. Before performing myocardial perfusion imaging, proper patient preparation is very important to ensure accurate and reliable results. First, patients are usually required to fast for 4 to 6 hours before the examination. However, plain water is generally allowed. Fasting helps reduce interference and improve image quality. Second, patients should avoid caffeine-containing products for at least 24 hours before the test. This includes coffee, tea, energy drinks, chocolate, and some medications. Caffeine can interfere with pharmacological stress agents and affect the accuracy of the study. Third, smoking should be avoided, preferably for at least 12 hours before the examination. Nicotine may alter heart rate, and blood flow, which can influence the test results. Next, a medication review is necessary. Patients should inform the healthcare team about all medication they are taking. Certain medications such as beta blockers, calcium channel blockers, or nitrates may need to be temporarily withheld according to the physician's instructions. Finally, patients are advised to wear comfortable and loose-fitting clothing, especially if they are undergoing an exercise stress test. In summary, good patient preparation helps ensure accurate image interpretation and improve the overall quality of the myocardial perfusion study. Next, I will explain the myocardial perfusion imaging workflow. The procedure begins with the patient preparation and assessment. The patient's identity, medical history, and eligibility for the examination are verified before obtaining informed consent. The second step is the stress test. Stress can be induced either through exercise such as treadmill walking or by using pharmacological stress agent like adenosine, dipyridamole, trigadenoson, or dobutamine. The purpose is to increase myocardial oxygen demand and evaluate coronary blood flow under stress condition. After adequate stress is achieved, a radiopharmaceutical tracer is injected intravenously. Common tracers include technetium-99m, Sestamibi, or Tetrofosmin. The patient then enters the uptake phase, where time is allowed for the tracer to circulate and accumulate within the myocardium. This waiting period ensures optimal tracer distribution before image acquisition. Next, SPECT imaging is performed using a gamma camera. Images are acquired from multiple angles around the patient to assess myocardial perfusion. Finally, the images are processed and interpreted by the nuclear medicine physician. Stress and rest images are compared to identify areas of ischemia, infarction, or normal myocardial perfusion. Overall, this systematic workflow helps provide accurate information about myocardial blood flow and supports clinical decision-making in patients with suspected coronary artery disease. Next, I will explain the image acquisition process in myocardial perfusion SPECT imaging. After the tracer has been adequately distributed within the myocardium, image acquisition begins using a gamma camera. The gamma camera rotates around the patient and acquires multiple projections from different angles around the heart. These projections are then processed by the computer to create detailed tomographic images of myocardial perfusion. In many cases, ECG gating is used during image acquisition. ECG gating synchronizes image collection with the cardiac cycle, allowing both perfusion and cardiac function to be evaluated simultaneously. With gated SPECT, several important functional parameters can be assessed, including left ventricular ejection fraction, wall motion, wall thickening. After acquisition, the images are reconstructed into three standard cardiac planes: short axis view, vertical long axis, horizontal long axis view. These reconstructed images allow physicians to evaluate the distribution of blood flow within the myocardium and identify areas of reduced perfusion. Overall, SPECT image acquisition provides both anatomical and functional information, making it a valuable tool in the assessment of coronary artery disease. Now, I will explain the appearance of a normal myocardial perfusion imaging study. In a normal MPI scan, there is a uniform tracer uptake throughout the myocardium during both stress and rest studies. This means the radio tracer is distributed evenly, indicating adequate blood flow to all regions of the heart muscle. As shown in these images, there are no areas of reduced uptake or perfusion defect. The anterior, septal, lateral, and inferior wall demonstrate symmetrical tracer distribution. In addition to perfusion assessment, cardiac function is also evaluated. In a normal study, the left ventricular systolic function is preserved, with normal wall motion and normal wall thickening during contraction. Another important feature is symmetrical myocardial activity. The uptake pattern should appear balanced without any significant difference between the various myocardial segments. Therefore, the interpretation of this study is normal myocardial perfusion, indicating that the coronary circulation is supplying sufficient blood flow to the myocardium both at rest and during stress. These findings suggest a low likelihood of significant coronary artery disease and are generally associated with a favorable clinical prognosis. Next, this slide shows an example of a normal myocardial perfusion SPECT CT study. This case involved a 55-year-old male patient who was referred for myocardial perfusion following a positive exercise stress test. When we compare the stress and rest images, we can see that the radio tracer distribution is uniform throughout the myocardium. There are no significant areas of reduced uptake or perfusion defect. The images are displayed in three standard cardiac planes. First is short axis SAS images at stress and rest. Second is vertical long axis VLA images at stress and rest. Finally is horizontal long axis HLA images at stress and rest. This view allows a comprehensive assessment of myocardial perfusion in different regions of the left ventricle. You may notice a mild decrease in tracer uptake in the basal inferior wall and septum. However, this is considered a normal finding and is related to the presence of the membranous septum rather than true pathology. Importantly, the tracer uptake pattern remains symmetrical in both stress and rest, indicating adequate myocardial blood flow without evidence of ischemia or infarction. Therefore, the overall interpretation of this study is normal myocardial perfusion, suggesting that the patient has no significant perfusion abnormality and adequate coronary blood supply. Next, I will discuss abnormal myocardial perfusion imaging findings, specifically the difference between reversible defects and fixed defect. The distinction is very important because it helps determine whether the myocardium is still viable and whether the patient may benefit from further treatment such as revascularization. First, let's look at the reversible defect. A reversible defect appears as reduced tracer uptake during stress, but normal uptake during rest. This indicates that the blood flow becomes insufficient when the heart is stressed, but returns to normal at rest. This finding is consistent with the myocardial ischemia, meaning the myocardium is still alive and viable, but receive inadequate blood supply due to significant coronary artery narrowing. Because the myocardium remains viable, patients with reversible defect may benefit from intervention such as angioplasty, stenting, or coronary artery bypass surgery. Now, let's look at the fixed defect. A fixed defect shows reduced tracer uptake in both stress and rest images. Since the defect persists in both studies, it suggests permanent myocardial damage. This finding is commonly associated with the myocardial infarction or scar tissue, where part of the myocardium has become non-viable due to previous ischemic injury. In this situation, revascularization may provide limited benefit because the damaged myocardium is no longer functioning normally. Therefore, when interpreting MPI studies, it is important to compare stress and rest images carefully. A reversible defect indicates ischemic but viable myocardium, while a fixed defect usually indicates infarcted or scarred myocardium. This information plays a major role in diagnosis, prognosis, and treatment planning for patients with coronary artery disease. Next, I will discuss the advantages of myocardial perfusion imaging or MPI. MPI is one of the most widely used nuclear medicine techniques for evaluating coronary artery disease because it provides both perfusion and functional information about the heart. The first advantage is that MPI is a non-invasive procedure. Unlike coronary angiography, no catheter needs to be inserted to the coronary arteries, making it safer and more comfortable for patients. Second, MPI has high sensitivity for detecting coronary artery disease, especially in patients with suspected myocardial ischemia. It can identify abnormalities in blood flow that may not be visible on other imaging modalities. Another important advantage is its ability to provide a functional assessment of the myocardium. MPI not only shows blood flow to the heart muscle, but can also evaluate cardiac function, including ventricular performance and myocardial viability. MPI also plays an important role in guiding treatment planning. By identifying areas of ischemia or infarction, clinicians can determine whether patients may benefit from medical therapy, angioplasty, stenting, or coronary artery bypass surgery. In addition, MPI can detect ischemia at an early stage, often before structural changes become visible on anatomical imaging studies. Finally, MPI is very useful in post-treatment evaluation. It can be used to assess the effectiveness of intervention such as PCI, CABG, or medical therapy by evaluating changes in myocardial perfusion after treatment. Overall, MPI provides valuable information that support accurate diagnosis, appropriate patient management, and improve clinical outcomes. Next, I will discuss quality control and diagnostic challenges in myocardial perfusion imaging. Although MPI is a valuable tool for evaluating coronary artery disease, several factors can affect image quality and interpretation accuracy. One of the main limitations of MPI is radiation exposure. Although the dose is generally low and considered safe, other limitations include attenuation artifact, motion artifact, long imaging times, limited spatial resolution, and the possibility of false positive or false negative results. Patient-related factors can also influence image quality. These include obesity, large breast tissue, inability to perform adequate exercise stress testing, and cardiac arrhythmias that may interfere with ECG gating. A common challenge in MPI is the presence of attenuation artifact. For example, breast attenuation can create an apparent defect in the anterior wall, while diaphragmatic attenuation may affect the inferior wall. Patient movement during image acquisition can also produce artifacts that mimic true perfusion defects. This slide shows an example of misregistration artifact. In the top images, the stress study appears to demonstrate a mild perfusion defect in the anterolateral wall. However, when the few SPECT CT and CT images are reviewed, it becomes clear that the transmission and emission data are not properly aligned. After correcting the registration, as shown in the bottom images, the apparent defect disappears and the myocardial perfusion is seen to be normal. This demonstrates the importance of quality control before final interpretation. Another important limitation is balanced ischemia. In patients with severe 3-vessel coronary artery disease, all myocardial territories may receive similarly reduced blood flow. As a result, the scan may appear relatively normal and produce a false negative result. Therefore, careful image review, artifact recognition, patient assessment, and quality control procedure are essential to ensure accurate diagnosis and avoid misinterpretation. Next, I would like to present a clinical case that demonstrates the importance of myocardial perfusion imaging in patient management. In this case, a patient underwent MPI due to suspected coronary artery disease. On the stress image, there was a moderate to large reversible perfusion defect involving the anterior wall and inferolateral wall of the myocardium. These areas showed reduced tracer uptake during stress, suggesting impaired blood flow when the heart was working harder. However, on the rest images, tracer uptake improved significantly. This pattern indicates that the myocardium was still receiving adequate blood flow at rest. Because the perfusion defect improved on the rest study, the findings were interpreted as reversible myocardial ischemia, indicating viable myocardium with stress-induced ischemia rather than permanent myocardial damage. Based on these MPI findings, the patient was referred for coronary angiography to further evaluate the coronary arteries. The coronary angiogram subsequently confirmed severe stenosis in the mid-circumflex artery, or LCX, which corresponded well with the perfusion abnormality seen on MPI. This case highlights the important clinical role of MPI. It not only detects myocardial ischemia, but also helps identify patients who may require further invasive investigation or coronary intervention. Although MPI provides valuable functional information, coronary angiography remains the gold standard for confirming coronary artery stenosis. Therefore, MPI and coronary angiography complement each other in diagnosis and management of coronary artery disease. To conclude, myocardial perfusion imaging, or MPI, is a valuable non-invasive functional cardiac imaging technique used in the assessment of coronary artery disease. MPI provides important information about myocardial blood flow and cardiac function, allowing clinicians to evaluate the physiological impact of coronary artery disease. It plays a significant role in detecting myocardial ischemia, infarction, and myocardial viability by comparing stress and rest perfusion patterns. In addition, MPI is useful for risk stratification, helping identify patients who are at higher risk of adverse cardiac events and may require further investigation or intervention. The information obtained from MPI also assists clinicians in guiding treatment planning, including medical therapy, coronary angiography, percutaneous coronary intervention, and coronary artery bypass surgery. In summary, MPI does not just show where blood flows, it helps clinicians determine whether myocardium is healthy, ischemic, or infarcted, enabling better clinical decision and improving patient outcomes. Thank you for your attention. I would be happy to answer any questions. Thank you once again for your attention and participation. We hope this presentation has provided a better understanding of myocardial perfusion imaging and its role in the diagnosis and management of coronary artery disease.